I know. But not because my recent
Well, hello, good afternoon. Welcome. We're glad you're here. Our students are glad you're here because they are super excited to check this off their list and want a graduation. But before they can do that, they need to do this part. So I'm just thankful for you guys to come today and just celebrate their achievements. We have 4 CSD students who will be in this section. Our first is Delaney Cohen. She is majoring in CSD with a minor in psychology. She's from Miami, Florida, and has been at SU for 3 years. And while she's been at SU, she's been quite busy. Student recruitment team and admissions, working part-time in Stillman Library, and our RA in Buena Vista. And this semester, she ran social media for National. Thank you, that's our club. And after graduation, she plans to attend Northeastern University in Boston and pursue her master's in speech development. So come on.
Hi everybody, like Mr. Hollis said, my name is Delaney Cohen and I'm a CSD senior. And today I will be presenting on communication barriers in pediatric ICU patients with intubation. So some key terms to know, the Pediatric Intensive Care Unit, or PICU for short, is a specialized unit for critically ill children. Intubation is a life-saving respiratory failure intervention, and augmentative and alternative communication, or AAC, describes multiple ways to communicate that can supplement and compensate for impairment and disability times. So the average length of the PICU stay, in a study that was done with 10,078 PICU patients, there was found an average length of stay of 5 days with a median of 2 days. Most patients stayed less than 48 hours, and they only accounted for 11.1% of total PICU days. Severe cases resulted in longer stays. So some psychological effects on PICU's patients are anxiety, frustration, fear, confusion, physical discomfort, and psychological distress. For the main portion of my study, we'll be focusing on the psychological distress. So this leads to my research question of how does early introduction of augmentative communication tools in a pediatric intensive care unit impact intubated pediatric patients' psychological well-being and clinical outcomes? So the study design, my study type will be a prospective cohort study. The population will be intubated pediatric patients in the PICU, and the setting is a tertiary care hospital. The control group is going to receive standard care with no AAC tools, and they'll serve as a baseline for the psychological outcomes and typical care. The intervention group will receive early introduction of AAC tools within 24 to 48 hours of being intubated. And this will include picture boards, communication devices, and or speech generating devices. And the objective of the study is to assess the impact of early AAC tools on psychological distress, communication satisfaction, and clinical outcomes. So the duration of the study will follow up throughout the pediatric critical care unit stay. It'll measure psychological and clinical outcomes in both the control and intervention group. So for my methodology, the inclusion criteria will be children aged 1 to 12 years old, and the condition they need to be intubated for at least 24 hours and admitted to the PICU. And the age range is 1 to 12 because that's the developmental stages that they need to be able to engage with AAC tools. And the intubation will ensure that there's a communication barrier for assessing AAC tool impact. So as for exclusion criteria, non-intubated but medically ventilated children will be excluded because they do not face the same communication barriers as intubated children do, because if they're mechanically ventilated, they're most likely on long-term life support. Children with pre-existing communication challenges like cerebral palsy and severe autism will also be excluded, only because they may not benefit from AAC tools as expected, and they can introduce a variability to the study. Informed consent is going to be required from parents and legal guardians of all of the participants, and the child consent will be collected if needed and appropriate. Withdrawal from the study is going to be allowed at any time without any repercussion. So the outcomes that I'm hoping to measure primarily will be focusing on psychological well-being, like I stated before. I'm going to measure anxiety levels using the state trait anxiety inventory for children. Frustration and emotional distress will be assessed through observational tools and self-report scales. So the self-report scales is going to be the parents reporting when medical staff is not interacting with the children. Communication satisfaction will be evaluated with the parent-caregiver surveys throughout their time in the PICU. And the length of stay is going to be compared between both groups to assess the impact of early AAC introduction. So the incidence of complications is just that I'm going to track medical issues like infections, and if the infections are still present within over a month of their stay, they will be excluded from the study. Recovery speed is time to extubation and need for additional interventions, and parental stress and involvement will be assessed through parental self-report surveys or interviews, and this will take place bi-weekly just to see where the parents' heads are at. As for data collection, the focus again is psychological well-being. So I'm going to be assessing this through two main factors: the pediatric pain profile, or PPP for short, and this measures pain, anxiety, and emotional distress, especially in nonverbal children, as well as the pediatric ICU environment, or PI for short, and this will evaluate the child's experience in the PICU, including factors like noise, light, and comfort, and how they contribute to the child's psychological distress. They're going to be used at regular intervals, particularly in the early stages of the PICU stay, because this is when anxiety and stress are most likely at their highest levels. So for my intervention is going to include the early introduction of AAC tools that will be tailored to the child's developmental level and cognitive abilities because they vary in ages. It'll look different for everybody. The tools will be introduced during the first 24 to 48 hours of intubation, like I said, because that is when the psychological distress is most likely at their highest due to being in an unfamiliar environment. And the specific tools will include picture boards, communication devices, and speech-generating devices. So to ensure the effectiveness of AAC, both medical staff and parents are going to receive training on how to use and incorporate these tools into daily care routines. Medical staff will include doctors, respiratory therapists, and nurses, as they're mostly the main people in the PICU. And the parents are going to be trained how to use the picture boards to communicate with their child, and the medical staff will be trained on how to use them during medical procedures or interactions with the child. So some clinical outcomes and communication satisfactions. I'm going to be doing some surveys and interviews that will be completed by the parents, caregivers, and medical staff at the end of their PICU, of the patient's PICU stay to evaluate the ease of use, the effectiveness, and the impact on communication. Parent and caregivers are going to give feedback in in-depth interviews to explore their experience with AAC and their child's emotional well-being. And medical staff is going to give insight to provide insight into how AAC tools impacted their care delivery, communication, and patient emotional state. So this is my timeline. I'm looking for the study to be a year, so 12 months. And there's 6 phases. Phase 1 is a preparation phase, which will take place in the first and second month. And this is when the staff and parental training is going to take place, as well as the procurement of those specialized AAC tools. Phase 2 is recruitment and enrollment, and that'll be months 3 and 4. And that's the participant recruitment, baseline data collection, parental consent, as well as the child assent if needed. Phase 3 is the intervention and data collection, and that'll take place in months 5 through 8. And that is the introduction of those AAC tools, the ongoing data collection, so the psychological assessments, clinical outcomes, and those communication satisfaction surveys. And then phase 4 is the post-intervention data collection and follow-up phase, and that's months 9 and 10. And those are those final psychological and clinical assessments and those follow-ups with the families. So phase 5 and 6 is more for the clinical portion of the study. That's months 11 and 12, and that's more of the statistical analysis, cleaning up the data, and doing those final reports. So some outcomes I would like to see is a shorter PICU stay because of reduced anxiety and promoting faster recovery, extubation, and weaning. Improved communication by decreasing complications and enhancing patient cooperation and satisfaction. And foster and stronger collaboration with children, families, and those healthcare teams. Clinically, it'll contribute valuable insight and support the development of evidence-based AAC guidelines. As for further research, long-term effects, it would be helpful to research and explore how AAC impacts the child development. As for expanded populations, studying AAC tools in other ICUs among children with specific conditions, and for cost effectiveness, analyzing the economic impact of those AAC tools inside of the PICU. So in conclusion, AAC tools can improve communication and reduce distress by enhancing clinical outcomes by representing a transformative step in pediatric critical care. And further research can help shape future practices and improve patient-centered care. These are my references. Are there any questions?
Yes. A question about your timeline. What have you thought about what would happen if a patient's discharged within that year? So what kind of data would you attempt to capture?
So obviously I can't force them to stay. If they are discharged, they will be excluded from the study because they're no longer intubated. So that's gonna cause variability in the
No, yeah, so they're gonna be no longer term.
yeah,
Okay.
because the focus is that they're intubated and trying to communicate while being intubated. So if they're no longer intubated, then they don't really.
Well, you wouldn't have the same patients for the whole year. It'd be like a
Yeah, it'll be
maybe
revolving.
study, right,
Mhm.
as they're going through. Can you back up? Did your hypothesis at the beginning? Did you have a?
My research question.
Yeah.
Yes.
Okay. Perfect. Really well done. I don't think I have questions. It was really interesting.
Anybody else? Thank you very much.
Next we were going to welcome to present will be Olivia Fenner, who's majoring in communication disorders with a minor in psychology. She's from Michigan and has been at Southeastern for 3.5 years. And while at SU, she's participated in intramural soccer, as well as some mission trips that I've done. And also, she plans to continue working as a registered behavior technician and plans to get her master's in to become a board certified behavior analyst. Wow.
Hello, everybody. I'm Olivia Fenner, and as she said, I currently work as a registered behavior technician. So I've chosen to look into the long-term impact of ABA therapy on conversation skills in children with level 1 autism. So the gap in previous research this far is that no previous studies focused on children between the ages of just 3 and 8, as well as none of those previous studies focus on just individuals with level 1 autism having no other diagnoses. And then none of the previous studies focus on the long-term impacts of ABA. So the purpose of my study is to hone in on one specific area. So we're going to be looking at what the long-term impact of ABA is on conversation skills in children with level 1 autism. And we're going to do this by looking into two different things. So we're going to measure the long-term impact of ABA in regard to staying on topic, and then we're going to measure the long-term effects of ABA on conversation skills in regard to turn taking and roles within a conversation. So some background about ABA therapy is that it was first proposed by B.F. Skinner, and he's now coined the father of behavior analysis. So his first invention that had to do with it was the Skinner box. So if you're not familiar with it, it was basically where he kept small animals within an enclosure and they had to press a button in order to receive food, water, or any other sort of reinforcement. And that led to the idea of punishment and reinforcement being used within ABA. So punishment is adding or taking something away from an environment in order to decrease the behavior, whereas reinforcement is adding or taking something away from the environment in order to increase that behavior. So that then led Skinner to come up with something called radical behaviorism, which he used to explain complex human behavior. And then Ivar Lovis was the first one to bring the approach of ABA to individuals with autism. The Behavior Analyst Certification Board was later established in 1998, but it wasn't until the early 2000s that ABA therapy began being pushed more and more into practice. So some key terms that we need to understand throughout this study are ABA therapy. So it stands for Applied Behavior Analysis Therapy. And this is mainly used with individuals with autism in order to help them live a more functional and independent lifestyle. And it's a treatment that's used to improve an individual's life through the analysis, understanding, and the prediction of a behavior. And then we also need to understand what autism is. So as we know, autism is a spectrum. It's called autism spectrum disorder. And it is defined as a neurodevelopmental disorder, and it's characterized by persistent impairments in social interaction and communication. ABA is something that is opposed by many professionals, including some speech-language pathologists, and this is due to the fact that when it was first implemented, it was seen as unethical, as well as it seemed as though those who implemented it wanted to get rid of the signs and symptoms of autism rather than promote and accept that diagnosis. So an example of this that some individuals believe is that ABA isn't promoting communication due to the lack of generalization. So people believe that you're getting an individual to elicit a response, but only when they're given a specific stimulus, so they don't think that that transfers out into the real world and that it would be useful anywhere outside of therapy. And then another thing that is opposed within ABA is the usage of social stories. So social stories are basically a book that's created in order to teach a skill, and that's used within the behavior skills training. And so they're opposed because people think that it's focusing on the normalization of those autistic behaviors rather than on celebrating that neurodiversity. And so the effectiveness of these social stories is also questioned because people think that they may cause more harm than do good because they believe that they're normalizing and promoting those problem behaviors. So here we have an example of a social story. So this one is about spitting. And so you can tell a client through and through, like, oh, we're not spitting, spitting's bad, that's gross, whatever. You can say whatever you want to them, but if it's not clicking, then you need to find another way, and that's where the social story may be implemented. So here it just says, like, no spitting, we should never spit at school, we shouldn't spit on our desk, we shouldn't spit on the floor, it can spread germs and make people sick, and so on. So one of those, using it in a different context, may really stick with that client, and it could help to decrease that behavior. And then within autism, there are 3 different levels of it. And within my study, we're only going to be using level 1 patients. So level 1 requires the least amount of support. They're the most high functioning, but you do see deficits in their social communication, as well as they may have difficulty initiating their social interactions. So these individuals may understand and speak in complete sentences, so they are verbal, whereas level 2 requires substantial support. So these individuals see deficits in their verbal and their nonverbal social communication skills, and they also have that limited initiation of social interaction. And then level 3 patients, they require the most amount of support. And so with those individuals, you see severe deficits in their verbal and nonverbal social communication skills. You see a very limited initiation of social interactions. And then all of those individuals are nonverbal, or if they are verbal, they just have use of very few words of intelligible speech. So then, like I said, for my study, I'm only using level 1 patients who have no other diagnoses. And this is just due to the fact that if they do have other co-occurring conditions, then it may affect the results because it could take longer for that treatment to work, or it could make there be a need for more treatment to be implemented. And then if we had used level 2 or level 3 patients rather than just level 1, you just wouldn't see those results as quickly. So in order to not see the results, we're only using level 1. And then also, why am I only using the ages of 3 through 8? And that's just because of the fact that most of the individuals who are receiving ABA at this time fall within that age range anyways, especially those who are entering for the first time. And that's one of the inclusion criteria is that they cannot have received any services in the past or be receiving them now. And that's just due to the fact that if they had or if they are receiving other services, you would see progress a lot faster than you would if they were just entering. So then how my study is going to be run, like I said, it's going to be children between the ages of 3 and 8 with a diagnosis of level 1 autism. So these individuals will be chosen from all over the state of Florida, and their parents or their legal caregiver will have to agree to have them be part of the study because our participants are so young. And then in order to complete the study, we're going to use a one-shot case study design. So this means that we're not going to actually have a control group because we are comparing the individual A pre-treatment results to their post-treatment results. So we're comparing them to themselves, just pre-treatment and then throughout and post-treatment. And then some inclusion variables, like I said, they need to be diagnosed with level 1 autism. They have to be verbal. They have to have no other diagnoses. They need to be between the ages of 3 and 8 at the time of intake. And then they have to have received medical services in their past or be receiving any other services now. And then for the exclusionary variables, that would be if they were diagnosed with level 2 or level 3 autism, if they had any other co-occurring conditions, if they were outside of that age range, or if they had received other services in the past, are receiving them now, or if they were nonverbal. And then for data collection, we're going to have the original intake, and then there'll be a checkup every 6 months for the next 5 years. And the reason that we're doing 5 years is because we're looking into the long-term impact, and that's when it becomes long-term, is that 5-year mark. And so all of this data collection is going to be done by the BCBA, which is the board certified behavior analyst. And then some different methods that are going to be used throughout the assessment, intake, and treatment is going to be something called socially savvy. So this is a checklist that will be used, and it determines the child's strengths and then their weaknesses and where they may need that extra help at. So that would help us to determine which skills need assistance. And then we're also going to use something called the BB-MAP transition assessment, and that will measure the progress of an individual over the duration of treatment. So that'll help us to see their improvement. And then we're also going to use what's called a BIP, or Behavior Intervention Plan, and this is developed by the BCBA. And so a BIP basically just outlines treatment for that individual, as well as it gives definitions of the behaviors that they may exhibit, and then it helps you know how you should deal with those and how you should treat them. So a BIP is different for every individual. Nobody's is going to be the exact same. But what we're going to do is throughout every individual in our study, we're going to implement 2 different techniques in their BIP no matter what. So we're going to implement the usage of social stories in order to teach those social skills. And so the skill that it's teaching may be a little bit different, but the social stories itself are still going to be used. And then we're also going to use something called Grice's maxims, which these are going to be used in order to teach the rules with how you should behave within a conversation. So then Grice's maxims, what are they? Like I said, they're used to teach rules in a conversation, and the creator, his name was Grice, and he said that you follow these 4 maxims if you want to engage in a meaningful conversation. And so the 4 maxims are quantity, quality, relation, and manner. And so the maximum quantity is only providing necessary information, nothing more and nothing less. The maximum quality is only explaining what you have evidence for, being truthful, and only saying things that you're able to back up. The maximum relation is only saying things that are relevant to the conversation and not straying off topic or doing anything like that. And then the maximum manner is to be clear, brief, and orderly in what you say within the conversation. So then here's my timeline. Like I said, we're going to have the original intake done. So during that, we're going to get demographic information, including their education history, their health history. This is where we find out if they had received any other services or are receiving it, things of that nature. And then we're also going to use the verbal behavior milestones assessment and placement program. So the part that we're going to use of that, there's different parts. And we're going to use the BB-MAP transition assessment. And then we're also going to use socially savvy. And then at every 6-month checkup, the BB-MAP transition assessment, socially savvy, and observing in different social settings is going to be used. So then the expected outcomes of my study are that the results would support that alternative hypothesis that ABA does have an impact on the conversation skills in children with level 1 autism. And this is largely due to the fact that there is, previous research already proves that ABA is recognized as the most evidence-based intervention, most effective evidence-based intervention for children who have ASD.
So then some of the limitations of this study are that it does only include children ages 3 through 8, as well as it is only done in the state of Florida. So some further research opportunities would be to examine which part of ABA has the biggest effect on social communication in regard to conversation skills in children with that level 1 autism. And then also we could look at the children who use PECS, which is the picture exchange communication system, see a greater increase in the conversation skills from ABA therapy than those who are verbal or who use other sorts of AAC devices, or who all forms show those same results. And so going along with that, we would need to study the other 2 levels of autism in the same regard, just to have some data to compare. And then lastly, we could do the same study in other states and then compare those results as well. Do you have any questions?
How many participants do you plan on having in this study?
So there would be no cap since we are comparing like them to themselves. Really, we could have as many as we want. I was looking at doing around like 100.
What was your hypothesis or your research question?
The long-term impact of ABA on conversation skills.
And so, do you know any percentages of the age of children that are between 3 and 8 that have never been diagnosed or have intervention?
No, so I don't have exact percentages on it. We are probably looking towards the lower end of that age range, just because as they get older, you would think you'd have more of a diagnosis.
Right.
With it being level 1, they are more higher functioning, so there is a possibility that that does go undiagnosed. So those individuals could still be part of the study, but yeah, we're looking probably more at like the lower end of that.
Good.
Anybody else? Perfect. And then I still up.
Welcome back. Thank you so much, Olivia. Next up, we have Lauren Martinez. She's majored in communication sciences and disorders and is from Riverview, and she's been at SEU for 4 years. And while she's been at SEU, she's served on SEU worship, admissions, student enrollment teams. After graduation, she plans to work at a daycare center working closely with children, working her way to management to then eventually opening her own center. She also plans to travel as much as she can and go anywhere the Lord sends her. Amen. Let's do it. So welcome, Lauren.
Hi guys, thank you so much for coming. My name is Lauren Martinez, as Professor Randall said. I have the opportunity to present my research proposal, which would be integrating speech-language pathologists into daycare settings, which would be a strategy to enhance early communication outcomes and reduce disparities. Now, my research question is, how does integrating speech-language pathologists into daycare settings influence children communication outcomes and reduce the disparities in early language development? Now, the problem in this is that children in daycare settings often face disparities in access to early intervention for communication challenges, especially those from undeserved or diverse communities. This lack of early support can lead to those delays in language development and impact academic, social, and emotional incomes later in life. Now, my hypothesis is going to test how children in daycare settings that integrate these speech-language pathologists, which are SLPs for short, which will demonstrate significantly improved language development, including vocabulary, sentence structure, and phonological awareness, compared to children in daycare settings without SLP services. Now, why does early language matter? Language development is foundational to social and academic success. There are 5 stages to the language development, which would go from infancy all the way to later school age. Each of these stages have different milestones that, from babies from 0 to 12 months, which is infancy, they're like babbling, cooing, and recognition of familiar sounds. And then I have toddlers from 1 to 3 years old, with which were the milestones would be first words, following complete sentences. And then preschool ages were from 3 to 5, which are vocabulary expansion and then forming sentences. And then early school age, which is 5 to 7 years old, which would be complex sentences and early reading and writing. And then later school age, which is problem solving and reading complex texts. And these first 5 years are very critical for brain development and language acquisition, and these delays can affect reading, writing, self-esteem, and their peer relationships. And the goal is to determine if early support will increase these long-term outcomes. Now, the two aims that I have came across is to analyze whether SOP in daycare settings could improve language skills such as 1, phonological awareness, which would be assessed using the literacy assessment system, and then 2, vocabulary, which would be assessed using the Peabody Picture Vocabulary Test, which is PVT for short. And for 2, to evaluate if integrating SOPs would increase knowledge of the daycare provider and the ability to implement early language intervention strategies measured through provider self-report surveys and structured observations using information checklists. Now I'm going to explain the two differences of the type of assessments that I would be using. So Access to Literacy Assessment System, which is for phonological awareness, which would be Atlas PA for short, is a new computer adaptive online assessment of phonological awareness. And it's developed for children from ages 3 to 7, and Atlas PA includes the subtests, including 3 different sections will be related to writing, pointing, and segmentation. And then Atlas PA was designed to be appropriate for children for typical development and as well for children who have disabilities related to speech production as well. Now the Peabody Picture Vocabulary Test, which I'll be using the 4th edition, which measures listening and understanding of single word vocabulary. Essentially, it's administered between one-on-one, and it's going to be a series of words, and they're going to be able to picture that in front of them, and they'll pick them right there. And it was developed from 6 months old all the way to 90 years old. Now, my population and what I would like to test would be from children from ages 2 to 5, daycare providers, and speech-language pathologists. And then the inclusion variables would be children involved into these daycare settings. Again, like I said, children from ages 2 to 5. And then I would like to do further testing into this one, but it would be no severe cognitive or developmental disabilities, because I won't be able to really figure out if the children that are getting tested now are going to be receiving any progress in what we're testing. So future testing would do severe cognitive. And then daycare settings willing to support the SOP sessions in person as well. Now the pre-intervention would be SOP conducting initial language screenings. So that would be before they enter the daycare, they would be able to get us initial language screening before they enter the daycare. And then teachers incorporating language strategies like modeling frequent verbal interactions and then using the rich vocabulary exposure into the daily routine of the daycare. And then post would be SOPs reassessing the children's language development like an exit test before they leave the daycare. Now, there are some challenges in accessing these services. Families face barriers like cost, transportation, and awareness as well. And then according to Thorough Publishing, access to speech-language pathology is often limited due to funding challenges, particularly for underserved populations. Many individuals face the barriers such as high out-of-pocket costs because it is not cheap, including as well as insurance coverages because not everything is going to be covered through insurance. And as well as the healthcare system isn't as strong as we would like it to be, so it causes the disparity in that as well. And they won't be able to receive the timely and effective intervention that they do need. Now, many delays do go unnoticed into the school age of 7+ years, which was the last stage of the language development that I had shown earlier. Now, many language delays in children do go undetected during early childhood and are not recognized until the child begins formal schooling. Now, the 3 implementations that I would like to include into this would be SOP activities into the daycare setting, which, like I said before, would be initial language screenings for all children who enter the daycare, and then group in one-on-one sessions targeting the specific needs for each child, because each child will have different needs as well. And then planning with the teachers to integrate these strategies onto the day-to-day basis as the schedule goes on in the daycare, and then parent coaching and taking home resources. Now, the training for staff, as many of you know, none of the staff is going to be able to diagnose the child because they are not equipped for that. So they will be working on workshops on developmental milestones and language strategies, coaching on descriptive language prompting and interactive play into the daycare, and then ongoing consultations to reinforce these new skills on a day-to-day basis, and then feedback between the SOP and the parents. And then as well as involving these parents. And parents are wanting to be involved in these children's lives, obviously, because they're putting them into this specific daycare. Now, information on these milestones and typical versus delayed development would be access to them, and they will have any type of concerns that they are thinking of. They could fill that out through a survey that will be implemented as well. And then bringing home-based activities to support the speech goals, like homework, basically, and then build trust and engagement from these families. Now, my projected outcomes, I came up with 2 different benefits for the daycare providers and then some of the benefits for the families. So for the providers, we'll be better equipped to notice and respond to these speech concerns, and then stronger confidence in addressing developmental needs, and then improved classroom quality through the language practices, and then again, having a closer relationship with the families and SLPs. Now for the families, having a greater awareness of language development milestones, increased access to professional support and resource, and then advocating for their children because that is their all, and then ongoing involvement in developmental progress. Now, some challenges and problems to the implementation that I was going to go into before. There is some limited funding for the SLP staffing. As many of you know, an SLP has a higher degree than a daycare teacher itself. So the funding will be completely different as like hourly rate in a way. An SLP wouldn't get paid the same way as a daycare teacher would in that specific setting. Scheduling conflicts can also be a big challenge in this because, as I said earlier, there's a group and there's one-on-ones as well. And depending on groups, that will be incorporated into the daily schedule. And then one-on-ones is basically like setting an appointment, but at the daycare. And then as well, there's a shortage of these trained pediatric SLPs. Now, in conclusion, integrating SLPs into daycare settings is effective and equitable. It improves language outcomes and school readiness, and it supports educators and families in these critical years, and it creates lasting developmental change for undeserved children. My acknowledgements, God, my parents, Zorian, and then professor and friends.
Your hypothesis had something about the disparate populations, right, or disparities?
Children in daycare settings that integrate speech language pathologists would demonstrate significantly
Okay.
improved language.
Your hypothesis, okay, so this is just your research question, I think. Right, so,
Probably, do you want it in the research question?
no, I was thinking, I didn't see anything in the implementation or the research design that really evaluated care and how you define that, but you did, your hypothesis didn't have that in it.
Okay.
So you're good.
Okay, thank you.
We're waiting for a mom, so we're glad to be on time. I want to thank parents too for your support. Last but certainly not least is Inez Mendez. She's a major in communication sciences and disorders. She's from Orlando, Florida, and has been at SU for 4 years. She's a track and field star. She didn't put that on here, but I can say. And after graduation, she plans to head back to school and pursue her master's in speech pathology. Welcome, Inez.
Alrighty, hello everyone. Like she said, my name is Inez Mendez, and my capstone presentation will be on alleviating adverse maternal health care experiences for pregnant women with specifically high-functioning autism. So to begin, I'm going to define what autism is. The National Institute of Mental Health, known as the NIH, defined autism as a neurological and developmental disorder that affects how people interact with others, communicate, learn, and behave. So, since we're talking about adults, the prevalence in autism in adults is 1 in 45, and then specifically in women is 1 in 100. So yes, this number is very low, but there is a lot of research that has proven that women can have undiagnosed autism due to their high social skills. So yes, we have great social skills. All right, so with women that are diagnosed with autism and are pregnant, there are some challenges that they can go through that not a lot of people can go through. Firstly, sensory sensitivities, which we'll get more into, and then communication difficulties, specifically with the healthcare providers, and then there's differences in pain tolerances, sometimes higher, sometimes lower. My research question is, how can maternal healthcare experiences be improved and effective intervention strategies implemented for pregnant women with high-functioning autism? So some background in my research. There was a gap in research, like I said. This is a very small group of people, and it's a very specific group of people. So there was limited research on that. And then some background information about what the training already looks like. A study was done on what staff training looked like when it came to ASD. It says that 1 in 10 professionals received level 2 autism training lasting about half a day. The term training was basically made in quotations because it felt like a lunchtime talk and not taken as serious. So the purpose of this study is to improve maternal health care experiences for pregnant women with high-functioning autism by shedding light to the challenges and implementing strategies for not only the women, but the healthcare providers too, and just giving them more specific training. So my first aim out of the two that I have is to evaluate the healthcare, their existing training for ASD patients, and develop a more enhanced and more specific training program that can better equip the healthcare providers with the knowledge and skills needed to provide high quality and inclusive care. So this will be an experimental qualitative study. In the population, we'll begin with an OBGYN, which is a medical doctor who specifically trains in women's health, pregnancy, and childbirth. Secondly, a midwife, a trained healthcare professional who provides care before pregnancy, during pregnancy, and after pregnancy. A registered nurse, a perinatologist, which is an OBGYN specialized in managing high-risk pregnancy, and this does count as a high-risk pregnancy because of their autism. And lastly, an anesthesiologist, which is a doctor who specializes in managing the anesthesia and other pain management. So my methodology for the first day, we'll start with the initial assessment, which is just providing interviews with the maternal health care providers, mainly in Lakeland, and the ones that I just listed as well, and then going into the training program. So some sample interview questions. We'll be asking them if they can describe their understanding of autism and how it influences the way that they do their patient care and approach them. Did you receive specific training, and how was it? How did you feel after that? And then the last two questions are mainly what if questions. So what if a patient with autism becomes overwhelmed during a routine checkup? How would you handle that situation? After this, Harvard University had a great course module that basically it's made for clinicians, and it's about treating patients with autism. This course is helpful because, first of all, it is free. We love free stuff. Secondly, it's made for clinicians. And thirdly, it's detail-oriented and will work as a base, a really good base actually for the second half of the training. So this is the first half of the training. These are what the modules look like. The first module, some misconceptions and facts about autism, some diagnostic criteria, and just a good little baseline. Module 2 is informed consent, shared decisions, making accommodations, communication techniques and tactics. Module 3 is transitions of care, health and social care, telehealth, emergency department stuff. And then lastly, module 4 is building a care team. It's talking about the advocacy for ASD, and this actually goes hand to hand with the second half of the training. So the clinicians will be given a week to finish this course and all these 4 modules. And after that, there will be a 2-hour training session that I will be doing, and it's conversational based, and it'll involve the teaching points and just intentional time through the intervention strategies that the woman will be using, which I'll get into in the second aim. After the application of the training, there will be a follow-up assessment. We'll basically be going right into the same interview questions and comparing and contrasting their answers. My second aim is to provide sensory support for pregnant individuals with ASD through a checklist that involves adaptations, desensitization techniques, and social stories to improve comfort and care. So participant recruitment, we'll be using an online recruitment platform, hopefully getting 15 women that are diagnosed with autism and are planning to get pregnant or already pregnant. And yeah, the online recruitment platform is DScout. Secondly, there would be an assessment and baseline evaluation. It's basically just an online survey that assesses the sensory sensitivity, comfort levels, and coping strategies. This is a great example of what it would look like. So we'll go into the all 5 senses, so specific light sensitivities, bright lights, flickering lights, sudden changes in lighting. How does that affect them? Does it affect them in a negative way or a positive way? And we'll go on with the sense sensitivities, strong sense, food smells, textures of food, sound sensitivities, loud noises, background noises, high-pitched noises, and then lastly, touch sensitivities, which is like clothing, physical touch from others, and temperature changes. This will basically measure their strengths and weaknesses and will give a grade base to what intervention will look like. Moving on, it's the fun part, which is intervention for these ladies. And this is what it will look like. It's a 4-week intervention plan. And week 1, we'll be working on the environmental sensory adaptations. So the lighting, noise, touch sensitivity, temperature, and aroma is basically the things that I was talking about in the first place, and in the last slide. Week 2, which is the daily routines and adaptations, schedules, food sensitivities, physical activity, and self-care. In their prenatal stages, we like to know what are some things that we can change to make this process easier for them. Week 3 will be on desensitization techniques, basically. This is the hardest part of the intervention because you have to apply what we learned in week 1. So it's gradual exposure to the hospital. You see, the pregnant women that have autism are they become very overwhelmed very, very quickly. So the lighting, the noise, the temperatures, and the touching from the doctors and everything, it can be very difficult and very overwhelming. So this will be gradual exposure to those things. So by the time they do have to get into the delivery room and deliver the child, we can figure out what are ways and different things that we can accommodate for them. For example, a weighted blanket for comfort. Lastly, week 4 will be social stories and comfort, and just for preparation, testimonies that can provide relief when anxious thoughts arise. Just basically a little heads up that, hey, you're not alone. You're not the only one that's gone through this, and this is how we're going to help you feel more comfortable in this. Now, after that, we're going to do a follow-up evaluation. After the 4 weeks of the intervention, we will be going back into the same assessment, and it'll basically be like a pre- and post-intervention test, answering the same exact questions and see if anything has gotten better, worsened, or all of those things. So my projected outcome is post-training, healthcare clinicians will have an increased confidence, knowledge, and adherence to the best practice in autism-informed prenatal care. My hope for this is that after the healthcare clinicians have received the proper training in a more intense training, that they'll be able to provide more inclusive and just overall quality care to these women. And secondly, the pregnant individuals with autism spectrum disorders are anticipated to be more prepared and have a reduced anxiety and just improved overall satisfaction with their prenatal care experience. That whether they're planning to get pregnant, are pregnant, or after, or they've already had their child, that they can just provide a sense of like just calmness and just less anxiety overall, and they'll just be more confident in this whole stage. So thank you to my parents, my coach, and my teammates, Professor Manvalis, and lastly, my Lord and Savior. Any questions?
Can you talk to me what data you're comparing? Like, how are you correlating what the professionals are? Is it going to be? Are they going to intersect, like the professionals and the patients?
So it'll be the assessment that they take in the first, like basically the interview. That'll be my form of collection of data. So basically, what have they already received? How are they feeling? How qualified do they feel in a way? And then after the intervention, the training is done, they'll be answering the same exact questions and seeing if anything has increased.
But you're not connecting like that these patients, how they feel connected, like related
The
to
patients as well too.
professionals.
Yeah.
So you're gonna match those up.
Yeah, everything will be matched up. It's just I put them into specific things so it doesn't get all like clustered in.
Okay.
So do you feel like that might be a good future
Yeah.
study to how can you intersect the data that comes from the women with healthcare provider training?
Yeah, a good way that I would do it is probably involve the intervention plan that I made for the women into the healthcare training, and I feel like that would be a good way to do it for future. So yeah, anything else?
Thank you. Can you guys just give the CSD students one more round of applause? That's all for this session. It's 12:48. The next session starts at 1 o'clock, I believe. Do you have, does anyone have the, I won't say bulletin because I feel like church, but if you see it at 1 o'clock, I believe there's the session, and then there'll be 2 lectures later on. So check your schedule and continue on enjoying today as we learn from our students. And thank you to our CSD students, thank you to your parents who came, and friends for supporting your friends. It's a lot of hard work that they do, and I'm very proud of them finishing strong because senioritis is real, right? So, thank you guys. Y'all have a great rest of your symposium.